Thank you, Hardik, for that warm introduction. And till my slides get loaded, um, so let's have a discussion or a dialogue before that. So my talk is on what's the drug choice in CKD, and CKD, the amount of CKDs that we are seeing today is enormous. I started my practice. So I started my practice 2 decades back in a suburb of Bombay called Andheri, and we had only 2 dialysis units then. We are talking about 96, 97. And today, in the same suburb, we have approximately around 10 lakhs people staying there. We have close to 700 dialysis beds. So in the last 2 decades, we have got 3,500% rise in CKDs and patient undergoing dialysis. And all these dialysis is happening 3 shifts in a day. So more the number of CKDs, we need more the number of diabetologists to prevent them from going into a nephrology complication and going to a nephrologist. So my topic is on OAD in renal impairment or CKD. I come from the city of Bombay. Epidemiology says that CKD is common and involves 25 to 30% of patients with type 2 diabetes. There's a paper from UNI in the last IDF which said that it's close to 40%. It's a leading cause of ASRD in US and in India. CKD in diabetes is now called as diabetic kidney disease, and most importantly, 25 to 30% of patients with diabetic kidney disease may not have proteinuria. So that's another, and we may not subject all of them to a kidney biopsy also. They may have background diabetic retinopathy, but may not have proteinuria. Why is CKD management different? Because kidney metabolizes approximately 25% of circulating insulin. The renal clearance of insulin is impaired. Renal gluconeogenesis, this is something which we don't realize, but we see it in practice, that in our chronic kidney disease, majority of the patients who may have a higher bedtime sugar suddenly have a fasting hypoglycemia. So their bedtime sugar may be 300 and their fasting sugar may be 55. That's because till now we have only understood that it's only the liver which gives out hepatic glucose output, and it's only the liver which is involved in gluconeogenesis. But kidney contributes a lot, and approximately 40% of our fasting plasma glucose could be contributed by renal gluconeogenesis. So in a chronic kidney disease of stage 4 chronic kidney disease, you may have this going down, and probably you may have a lot of fasting hypoglycemia. There's an increased risk of lactic acidosis also. Concurrent renal anemia is very common, and secondary hyperparathyroidism influences the long-term outcome. And again, as we know, CKD is almost like a CHD risk equivalent. There's a sub-analysis of the UKPDS trial where the patients of chronic kidney disease were follow up over a period of 10 years. And what it showed, that the chances of a patient with CKD progressing to the next stage of CKD is very less, as compared to that the patient is at much higher risk, almost 2 or 3 times, to die of cardiovascular disease. So most patients of CKD may not progress to the next stage of CKD, but at much higher risk for cardiovascular disease. And most commonly, the cardiovascular problem which comes in CKD is pump failure or heart failure. Now, staging of kidney disease is always based on GFR. So stage 1 is where you have kidney damage with a GFR more than 90. Kidney damage, stage 2 is when your GFR is between 60 to 89. Stage 3 chronic kidney disease or DKD is when your GFR is between 30 to 59. Stage 4 is between 15 to 29, and when you're in stage 5 or end-stage renal disease, as it used to be called, patient will require dialysis. Now, GFR, how to estimate? This is the MDRD formula, and we should express it in ml per minute per 1.73 meters square. That's the way one should estimate the GFR. It's very easy. You have a lot of calculators which can be on your laptop or on your handheld smartphone. Now, hypoglycemia is the most common complications in clinical practice apart from heart failure in patients with CKD, and this is data from Japan in a hospital called Red Cross Hospital, and over 57 cases out of a total of 6,000 patients were admitted with impaired consciousness because of hypoglycemia. And if you look at it, majority of the hypoglycemia is in stage 4 and stage 5 CKD, where if you see the red dots, is purely sulfonylurea-induced hypoglycemia or insulin-induced hypoglycemia. So probably the time has come that probably we need to save these patients from hypoglycemia. And if you remember my talk from the morning, hypoglycemia itself is a serious risk factor for major adverse cardiovascular events, cardiovascular mortality, and cardiovascular death. So hypoglycemia itself identifies that vulnerable patient who needs to be taken good care of and is a huge risk factor for cardiovascular disease. So hypoglycemia is something which is very common in patients with chronic kidney disease, and we should use probably insulinotropic agents or probably insulins which have a shorter half-life and make sure that patient does not go into hypoglycemia. The challenges with renal impairment and OADs, problem with metformin is drug accumulation. Sulfonylureas, again, the longer acting sulfonylureas should be avoided. The shorter acting ones are preferable. TZDs, as we know that TZDs cause fluid retention. Patients with CKD are very high risk for heart failure, so that could be a problem. Alpha glucosidase inhibitor, also there's drug accumulation. SGLT2 inhibitors, the basic mechanism of action is dependent upon the glomerular filtrate, and if your kidney is into a dysfunction, they may not work. Insulin, again, the impaired catabolism and clearance of exogenous insulin results in a kind of difficulty in dosing and probably hypoglycemia as well. The challenges with renal impairment and OADs, you can use a shorter acting sulfonylurea if you have to use something like glipizide, which is widely used in CKD. If the patient can't afford a meglitinide, it's always better to use it. You can use it up to a GFR up to 30. Glimepiride you should use with caution and probably up to a GFR of only 60. Pioglitazone, there's no dose adjustment, but make sure when you use pioglitazone, the patient is not in early heart failure. Metformin is controversial, but metformin can be used up to a GFR of 30. Acarbose, again, and Miglitol do not use if the creat is more than 2 or probably in stage 3 CKD. SGLT2 inhibitors, canagliflozin has a dosage adjustment to 45 if you are using 100 milligram once a day. DAPA, you can use it till 60, and empagliflozin up to 45 GFR. So basically, if you are in stage 4 CKD, the SGLT2 to be used for reduction of blood sugar control doesn't make sense. GLP-1, again, if you're in stage 4 or stage 5 CKD, you may not use them because, again, it causes a lot of nausea, and these patients are already into early uremia. Liraglutide does not require any dose adjustment, but use caution and you need to titrate the dose. Now for metformin, it has been controversial. Metformin has widely been used in our country, and metformin and CKD, and we always have our tiff with our nephrologist whenever he goes to a nephrologist, and even if the patient is in stage 3 CKD, the nephrologist withdraws metformin, and what you see is that the sugar rises up 3 times. And we have a discussion with the nephrologist, and nowadays the nephrologists have got much more lenient, but up to 60 there's no renal contraindication, but you should monitor the renal functions. Between 60 to 45, continue use, increase monitoring of renal function. Between 45 to 30, prescribe metformin with caution, use a lower dose because these patients require much lower doses, or half maximal dose, but do not start new patient at a GFR of 30 to 45. That's extremely important. If you have a patient in probably stage 4 CKD or stage 3A CKD, you may not start metformin, but if the patient is on metformin, you could reduce the dose or go on to the half maximal dose of metformin. Below 30, preferable not to use metformin. In terms of DPP-4 use, we all know that we can tweak the dose a little bit, and probably you could have most of the DPP-4 used in CKD. Linagliptin and alogliptin do not have much of renal clearance, and they can safely be used at the same dose. In terms of CETA, you can use it at 25 mg in stage 4 and 5 CKD, that's even in dialysis patient, and patients in stage 3 CKD, you can use it 50 milligrams. More than 60 ml, you can use up to 100 milligrams. Saxagliptin also needs a small tweak of dose itself, so there is no reason to not use a DPP-4 inhibitor in a patient with CKD, whether it's stage 1 to kind of stage 5 CKD. So all of them can be used just with a tweak of dose. Linagliptin and teneligliptin does not require a tweak dose at all. So if in a nutshell, if you could see, SGLT2s to be used up to 45 in terms of canagliflozin, the other two up to 60. Metformin up to 30. Between 45 to 30, do not initiate metformin, reduce the dose, reduce the submaximal dose, make it half the dosage. Sulfonylureas, preferably use glipizide because shorter acting. If you are using a glimepiride up to only 60. GLP-1 analogues, again, I'm not a huge fan of GLP-1 analogues in CKD because nausea is very high, but up to 30 you can use. Acarbose, again, has drug accumulation. Pioglitazone you can use up to 15, but the problem is of fluid accumulation. Repaglinide and natiglinide, unfortunately natiglinide got withdrawn in our country, repaglinide is still there, and repaglinide becomes a very good drug to be used in CKD because it has that tagline of one meal, one dose. We know that majority of CKD patients have very poor appetite and are anorectic, so you could give it before or after a meal. Insulin obviously is the drug of choice in CKD, and we know that DPP-4 inhibitors could be used in patients with hemodialysis also with a small change in dosage. Now these are not head-to-head studies, but there's data on linagliptin where it's shown a reduction in the newer progression of microalbuminuria in its studies, and the similar studies with vildagliptin as well as sitagliptin. The SGLT2, because of its action on the efferent arteriole, slows the decline of eGFR and reduce albuminuria and nephroprotection. If you go back into history, whichever drugs have kind of reduced the deterioration of the GFR have had benefits on CKD and also on overall cardiovascular disease. So if you revisit studies of losartan, which was renal, or irbesartan on IDNT, they all were irreversibly reduced the GFR, and they had benefits on CKD and also had emergent risk reduction in cardiovascular disease over decades. This is a consensus statement by Dr. Rajesh Rajput and colleagues on insulin therapy in chronic kidney disease, especially in India. If you look at it, the expert recommendation in dosing and titration of insulins in CKD is if your GFR is more than 60, there's no reduction required. Between 60 to 15, you should reduce the insulin requirement by 25%. Less than 15, you should reduce by 50%. The expert route also says about the dose estimation of insulins in patients with CKD. So if you are more than 60 GFR, if it's a type 1 diabetic, it's 1 unit per kilogram. If it's a type 2, it's 0.5. Between 60 to stage 4 CKD, if it's a type 1, it's 0.75, but if it's a type 2, it's 0.3 to 0.04 units per kilogram. In patients with end-stage renal disease or stage 5 CKD, if they're type 1, it should be 0.5, and if they're type 2, it should be reduced to 0.25 units per kilogram. And the HbA1c targets also has to be kind of little lenient, and we have to relax it. So if you are less than 60 GFR, you probably need to go between 7 to 8%. So in conclusion, I would say that diabetes is the most common cause of end-stage renal disease. Diabetic kidney disease is 1/3 is without proteinuria. So if you don't have proteinuria, it may not be a non-diabetic kidney disease. Modifications of anti-diabetic drug is required with progressive renal insufficiency. Insulin therapy is possibly safest in renal failure. ACE and ARBs are cornerstones in the management of diabetic kidney disease, but secondary anemia as well as secondary hyperparathyroidism need to be treated for long-term outcome. Thank you so much.